Hi there, I hope you guys are all having a great last week of your semester. This is my presentation on nutritional support for patients around liver transplant. So first let's go over the phases of a liver transplant because that's how we'll be breaking down the information about nutritional support today. Liver transplant can be divided into 3 phases. The first phase is pre-transplant. This begins at the time that the patient decides, along with their care team, that they need a transplant, until the time when they actually undergo the procedure. Patients need a liver transplant when they are in liver failure from a disease like cirrhosis or liver cancer. They are usually put on a waiting list and are cared for in the pre-transplant phase until they match with a donor. The main focus of nutritional support in this phase is building strength for the surgery and dealing with the various complications that come along with end-stage liver failure. The acute transplant phase begins immediately after the procedure and continues until the patient leaves the hospital. This usually takes between 2 and 6 weeks. Nutritional support in this phase focuses on recovery from surgery and the prevention or treatment of acute complications. The chronic post-transplant phase begins after the patient is strong enough to leave the hospital and extends for the rest of the patient's life. They receive mainly outpatient care at this time, and the main focus of nutritional support is reducing the risk of chronic diseases associated with liver transplants. Alright, let's jump right into pre-transplant nutritional support. So our first concern is malnutrition, which is really common in the pre-transplant stage. It is a risk factor for mortality and morbidity, so we want to treat this aggressively. Many patients have edema, so using BMI as a tool may be inaccurate, and things like skin fold measurement are probably better. It is recommended that patients consume 30 calories per kilogram per day prior to the surgery. Appetite stimulants may be used to increase oral intake. Patients should be encouraged to eat energy-dense foods and may be prescribed oral nutrition supplements. If a patient doesn't consume at least 25% of that 30 calorie per kilogram per day, it's recommended that they receive enteral or parenteral nutrition, because at this low intake, patients are at higher risk of severe infection within 3 months after the surgery. Another concern is fluid retention. When fibrotic tissue in the liver blocks blood flow from the hepatic portal vein, circulation will actually detour through the submucosal veins of the GI tract. The extra blood in this area can lead to discomfort when the patient consumes even normal volumes of food. Meals can be small and frequent to prevent feelings of fullness. In addition, beverages should be consumed away from meals so that the patients don't feel uncomfortable before they've eaten enough. Portal hypertension can be lessened through sodium restriction. Dietitians must carefully balance the need to reduce sodium to reduce this fluid retention with the need to make food palatable enough for a patient that's already less interested in food. For this reason, the recommendation is to begin at a level of 2,000 milligrams of sodium per day. It's also important to remember that patients in liver failure are already at higher risk of hyperkalemia, so potassium salt substitutes should not be used. 40 to 50% of people with cirrhosis have fat malabsorption. Fat malabsorption can cause diarrhea and further weight loss, so it's absolutely crucial for patients with fat malabsorption to be identified and treated promptly. We can use a fetal fat test to diagnose this condition. If it is diagnosed, the patient should be started on a low-fat diet. Although MCT oil is expensive, it is a good option to replace dietary fat and be able to increase calories for patients with fat malabsorption. Fat malabsorption can also lead to the excretion of fat-soluble vitamins, so we want to screen patients for fat-soluble vitamin deficiencies if they test positive for fat malabsorption. If deficiencies are present, patients should be prescribed a water-miscible supplement to make up these vitamins. Zinc deficiencies are also common at this stage, and this can result in altered taste and smell, which is a big concern when we're trying to encourage patients to eat more. If zinc is supplied and taste and smell are restored, we can increase dietary intake. In addition, zinc is implicated in the metabolic condition hepatic encephalopathy, which is a big concern for liver disease. Zinc supplementation is correlated with improved encephalopathy, which is great. Okay, let's talk about acute post-transplant needs. So patients have some altered nutrient needs during this phase. First, they're going to need increased protein at 1.3 to 2 grams per kilogram per day. Patients are at high risk of infection, and increased dietary protein allows for the synthesis of immune system proteins and enzymes. In addition, these patients have increased protein needs to rebuild body tissue damaged in the surgery, because this is a pretty major abdominal surgery. They're also going to have higher general energy needs, which is going to be at about 120 to 130% of basal energy expenditure. In addition, one very common complication is fever, which is going to even further increase energy expenditure. So patients in this stage continue to be at pretty high risk for malnutrition. In addition, there is also increased sodium loss. So while before in the pre-transplant phase we were limiting to less than 2,000 milligrams of sodium per day, now patients may need up to 4,000 milligrams of sodium per day. There are a lot of challenges to meeting the nutritional needs of patients in the acute post-liver transplant phase. First, there are a lot of new medications, and one of the big side effects is early satiety and taste changes. In addition, a lot of patients aren't able to eat orally for at least the first 2 to 5 days after the surgery because they experience excessive nausea and anorexia. In addition, a lot of patients also have diarrhea, which is going to increase their fluid, sodium, and energy needs. It might also take a while for their GI system to begin functioning again because, remember, the liver is an accessory GI organ. So that may result in a non-functional or slow GI function. It's also hard for patients to even receive diet information because a lot of them have poor attention span, fatigue, and brain fog after this major surgery. In an acute care setting where malnutrition is a concern, we need to decide if we're going to be using enteral, parenteral, or oral feedings. So as we discussed on the last slide, most patients can't eat orally right after surgery. This means that it is ideal to initiate tube feed within 12 hours post-operation. In addition, we really want to avoid parenteral feeding because patients are at a high risk of catheter-related sepsis right after the surgery because they are on immunosuppressing drugs in order to prevent the rejection of this new tissue in their body. We're also going to want to encourage small, frequent meals once they return to oral feedings in order to prevent early satiety. But oral feeding should not be resumed until patients can consume 2/3 to 3/4 of their estimated energy needs. So moving into the chronic post-transplant period, our main goal is to prevent chronic diseases, many of which are at a much higher risk for patients who have undergone liver transplant. So for unknown reasons, many patients gain excess weight after this surgery. Some thoughts are that it could be as a result of steroid medications being used in the long term, which is really common for this surgery, or it could also be a result of metabolic changes due to the long-term malnutrition that many people experience prior to liver transplant surgery. Another disease of concern is cardiovascular disease. So the recommendations are to eat at least 20 grams of fiber per day, get less than 30% of calories as fat, and less than 10% calories as saturated fat. Another big concern is osteoporosis. Many patients being malnourished for a long period of time prior to their transplant don't consume enough vitamin D and calcium, and they also don't perform any weight-bearing activities, which really sets them up for osteoporosis. So it's encouraged that after their transplant surgery, they consume 4 servings of dairy per day. And if they're a woman over the age of 25 who doesn't consume dairy, they should be taking a vitamin D and calcium supplement at the RDA. Another concern associated with the chronic post-liver transplant period is cancer. So to prevent this, it's recommended that they consume a diet high in vegetables, fruits, and whole grains. In addition, they should be educated about food safety in order to try to consume as few carcinogens as possible. So this is just a quick overview of the care team that's involved in a liver transplant. So, of course, we've already discussed the dietitian's role. Hepatologists typically oversee the care of the patient before and after surgery when they're in the hospital. Psychologists can help a person cope with this major life event. During the surgery, anesthesiologists, surgeons, and nurses all work together to perform the procedure. In addition, the nurses are going to be caring hands-on for the patient before and after the surgery while they're in the hospital. Occupational therapists can help patients cope with decreased ability to care for themselves or work and devise adaptations to preserve energy. Most patients who receive liver transplant will continue to take immunosuppressive medications for the rest of their lives, and these medications often have skin complications. This means that following up with a dermatologist at least yearly is essential. Social workers can provide counseling or help coordinate assistance while the patient is ill and might be unable to work for a long period of time. Another important member of the care team that we might not think about is a dentist. So after a transplant, patients are at increased risks of dental caries, periodontal lesions, and oral fungal infections. So a dentist is going to be pretty essential in helping prevent and treat these complications. A physical therapist typically will see a patient while they're in the hospital and may follow up with them after in an outpatient capacity. And they're going to help the patient engage in weight-bearing activity to reduce the risk of osteoporosis in the long term, and in the acute setting can help them return to regular activities of daily living after this major abdominal surgery. Finally, a primary care physician is going to be the person providing care for the patient in the chronic post-transplant liver phase and assist in preventing and identifying complications in chronic diseases. Here are just a couple of PES statements. There could be so many more, but I just have 3. So for the pre-transplant phase, we might say excessive sodium intake related to cirrhosis as evidenced by intake of 3,000 milligrams of sodium per day, fluid retention, and portal hypertension. A sample from the acute post-transplant phase might be inadequate oral intake related to loss of appetite secondary to liver transplant as evidenced by consumption of 700 calories per day and nausea. For the chronic post-transplant phase, an example is food and nutrition-related knowledge deficit related to no diet education about osteoporosis secondary to liver transplant, as evidenced by inadequate vitamin D and calcium intake. And here is my work cited. Thank you for listening. Have a great day.